if you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Jacob, it has been a long time since we've talked about poop sacs, and I feel like we've been neglecting them. And poop sacs don't like to be neglected. When you neglect poop sacs, they get angry. They get gassy. They fart a lot.
Yeah.
So I think we should talk about
That's
some poop
true.
sacs. I was looking back, and I think it's been 12 years since we've talked about poop sacs on the Ultrasound podcast, which is hard to believe.
Yeah. Yeah, I think you're not estimating it correctly. I think you were 12 years old when this happened. So it's like it's been like even way longer than that.
Actually,
so there's a bunch of bowel stuff we can talk
about. It would be
about.
believable if we were saying you were 12 years old.
That's true because I'm actually 15 right now.
Okay.
So it really
That
wasn't
makes
that
sense.
long ago.
All right. Tell me about some poop sacs.
So there's a lot of things we can talk about, Mike. But we're going to focus in on a few of these. But today, we're going to do this in a couple parts. Today, we're going to talk about small bowel obstructions and hernias. Mike's going to talk about hernias. I'm going to talk about my favorite thing about the poop sacs, and that is adult small bowel obstruction. Now, Mike, I know that you have a favorite small bowel obstruction article, right? I mean, everybody's got to have one. This is mine. It's a little... It's a little bit of an older study. It's like 2013, but it's like a phenomenal meta-analysis. So what they did was they compared history and physical, X-ray, and ultrasound, MRI, and CT. They compared all of those together. And the gold standard was basically like clinical diagnosis. So what did they do after their hospital discharge? Or what were the surgical findings? So pretty good gold standards. Now, I don't really have access to abdominal MRI for small bowel obstruction. I don't know. Did you have that, Mike, in like Utah, or do you have it where you're at now?
Abdominal MRI?
Abdominal MRI access.
I mean, maybe, but it'd take like 12 hours. It's probably not the first
Right.
choice.
I got it. So let's just take that one out. And let's just talk about these things, which are things I think most of us have access to. That's history and physical, ultrasound, X-ray, and CT scan. And they kind of just compared all of these kind of as head-to-head as they could. And what they found was, unsurprisingly to me, that small bowel obstruction, in the diagnosis of small bowel obstruction, ultrasound was better than X-ray and better than the history and physical examination. Does that surprise you?
I feel like we've had
Mike?
this
I mean,
conversation
what's your
before.
experience?
Have we had this conversation before? Like, could you just take small bowel obstruction out of that slide and put in any ultrasound diagnostic modality?
Right. Yeah, exactly right. Now, one of the things that I want to talk about, because like actually, you know, my residents, like even my second, third year residents, usually off service, not really like the emergency ones necessarily, but they always, when they have a patient that they think might have small bowel obstruction, they ask me, can we do like an X-ray as like a screening test? And I basically show them this literature right here. These are pretty bad sensitivities and specificities. I mean, we got sensitivity in the Jang study of 46%. This 1991 study, 66 to 77%. Specificity is pretty low too. I mean, basically to me, if you use X-ray in the evaluation of a small bowel obstruction, it's basically kind of like doing a coin flip. Like if you do a coin flip, sometimes you actually might be more accurate than your X-ray would be at ruling it in and ruling it out.
So are we talking about
about
X-ray for pneumothorax and trauma? Or are we talking about small bowel? I feel like we've had this conversation so many times. Why are we still using X-ray for small bowel obstruction? It doesn't make any sense.
Yeah, no, I'm with you. And I did a pretty extensive literature search, and those two studies that I showed earlier, those ones were the ones that had the best gold standard, which is essentially either a CT scan or surgical findings. Some of the older textbooks that a lot of the newer articles will refer to give better numbers for X-ray, but it's kind of like this like shell game. You know, you try to follow it back to the original source, and the original source either doesn't exist or the original source's gold standards were awful. And those two studies I showed you, that Jang study and that Shrake study, were the only ones that had good gold standards that I could find. So I think that even though some of the literature says that the accuracy is a little bit better, I don't believe that data because the gold standard's shit. Wait,
Fair
can
enough.
I cuss on this podcast?
I mean, I guess so. If we
I'm not sure if I'm allowed to curse.
No, we can bleep it out if we need to. If we get complaints, we'll bleep it out.
All right. Now, one thing that's weird about this is that it showed that ultrasound was as good as CT scan. Do you buy that? I mean, what do you think about that data point right there? It says ultrasound's pretty much as good as CT scan.
Well, I don't know.
Is
What
that
are we
like
looking
what you've
for?
seen?
I mean, I guess compared to our gold standard of surgical, what's our gold standard here?
So our gold standards were okay, but my problem, and this is one of the things that you have to do about like making sure that you look at the literature and read the literature well, is the slice thickness and how old the studies are. Even though this publication was done in 2013, these are kind of like older studies, right? Mostly in the 90s, maybe early 2000s, and their slices were a lot thicker than what we typically use these days. So, I mean, look at the slice. It was like
Yeah,
5 centimeter
50
slices.
millimeter slice. Whoa, that's a thick slice right
crazy.
there, buddy. No slice at all.
Right, no,
They
no
didn't
slice
even-
at all. It
they
was
didn't
just
even
like,
use
It
slices.
was essentially like one X-ray. That's what they were doing.
They were doing.
Just, like,
They're actually doing
slices.
chunks at that point.
Right. So take this information with a huge grain of salt. I mean, even though this says that ultrasound and CT scan have like a decently equivalent sensitivity and specificity, I think that the ultrasound is definitely not as good as the X-ray, but it's better than everything else that we have for bedside diagnosis. So H&P X-ray, it works well. And look it down here. I mean, if you look at the which is probably my favorite name that I've come across while researching this, Porn Sup. If you look at the Porn Sup study right there at the bottom, 2009, they had like the normal slice thickness, and they had a positive likelihood ratio of infinity and a negative likelihood ratio of 0.04. So I think that number reflects the actual accuracy of CT scan, and the accuracy of ultrasound is good, but it's definitely not that good. So CT scan is still kind of like our de facto gold standard, and ultrasound is, I think, second place right behind the
Fair enough.
CT
Fair enough.
scan.
I can buy that.
Yeah.
So that's great, Jacob. Ultrasound is useful. CT is better, but how do we even do the ultrasound for small bowel obstruction?
That's a great question, Mike. So first thing is probes. We want to use the curvilinear transducer. This is actually happens to be my favorite transducer because I can do a lot with it. It's also really good for lungs, which is kind of my jam. But if you don't have a curvilinear transducer, you can totally use the phased array transducer.
You know, it's always
Does
it's
it
important
well-
to have
does
a
it
phase
as well?
It's important to have a favorite transducer. That's everyone has to have their fave.
No, everyone probably does, Mike. So this one happens to be my favorite. The phased array transducer the image won't look as good as the curvilinear because the phased array transducer has a lower frequency. Lower frequencies penetrate a little bit deeper, but the image doesn't look as good. You got to think about like bass and treble for your stereo system. It's kind of the same concept. What you're looking for here is you're looking for bowel that is greater than 2.5 centimeters and non-collapsible. The non-collapsible is kind of like the biggest thing for me because sometimes I swear that I see bowel that transiently is like 2.5 centimeters, but then it like goes down to like no centimeters because it's actually peristalsing just fine. The other thing that is kind of mentioned here and there and that I kind of use clinically is the back and forth movement of the poop. So if you see this huge greater than 2.5 centimeter small bowel, the bowel is not collapsible, we see back and forth poop movement, you should highly suspect a bowel obstruction.
I got to say, I really like the back and forth poop movement. I've seen that quite a few times clinically.
Yeah.
And in most cases, when people do actually have a small bowel obstruction, I see the back and forth peristalsis. So I'm a big fan of that. Although you got to remember that it's not always going to be there. I think the presence of it will help increase the specificity of your exam, but the lack of it does not rule out disease. So I think it's got a good specificity, but poor sensitivity. Whereas the dilated loops has a higher sensitivity, if that makes sense. But it's also important to remember that
totally right.
you can get closed loop obstructions. So you can get a single loop. It doesn't have to be multiple loops. It can just be one single loop that's kind of twisted in on itself, which I've seen a couple of times actually, and can be super hard to diagnose on ultrasound. Possibly part of the reason that CT is better than ultrasound for the diagnosis of small bowel obstruction.
Yeah, no, that's a super good call. Makes perfect good sense. Now, as far as placing the probe, a lot of people will place a probe on the anterior wall, so kind of like up here. Where's my cursor? Up top, like in the belly button. But the problem is that with small bowel obstruction, I mean, remember, I hate to mention X-ray, but just to kind of prove a point. The X-ray, they talk about air fluid levels, like you'll have these air fluid levels in the bowel, and if you place in the anterior wall, you'll get more of that air, and that air blocks sound waves. You won't be able to see as well. So I actually place the transducer pretty lateral, so right kind of above the pelvis. So I'll place it right above the pelvis, right about here, and aim the transducer towards midline, and that's usually where I find my small bowel obstructions.
Put it right above the pelvic.
Do you want to know what normal poop looks like?
Put it right above the pelvic.
Right above the pelvis. Well,
Yeah,
I mean, the space between like right above the pelvic,
Yeah.
the space above the pelvic and the space below the ribs, like there's not a whole lot of space up there. So I like placing it just like right above the pelvic.
Welcome
right
to
there.
the anatomy podcast. I place probe above pelvic. So I agree with you on that one, Jacob. I will say that I do start anterior because sometimes you get just fluid filled as small bowel obstructions, and there's
Yeah.
actually no air fluid levels, which is one reason X-ray is not so
Yeah.
good at this, because if there's no air, then it's hard to see the fluid levels. So I start anterior
fair.
as well, but usually see gas just like you do, and find my way laterally pretty quickly just above the pelvic.
Okay, right above the pelvic. So, Mike, this is what do you think? Normal or abnormal?
I see poop moving. I see poop sac. That looks pretty. That's
Right.
pretty
It's
normal,
not
buddy.
dilated.
I think like I see a lot of movement. I
Yeah.
don't see any fluid. There's nothing dilated. I don't see any walls. Yeah.
Yeah, nice, good call. So I think that's probably a normal bowel. So you don't always see bowel when you're looking at the abdomen, but if you do see bowel and it's not pathologic, it will look a lot like this. What do you think about this guy right here?
So that's starting to look a
Totally.
little dilated. I see some
Yeah.
schmutz in the middle, and the schmutz is not moving much.
Yeah, right here.
Which suggests
Is it collapsing?
I don't see any peristalsis actively, and I don't see any collapsing. But I don't know that you're pushing on it. So if you're pushing on it, it doesn't look like it's collapsing.
Right. The other thing too is that if you look right below the bowel, you see how there's like maybe a little bit of hypoechoic, maybe some
Yeah, a
fluid
little free
underneath
fluid
it,
under
right?
that
It's kinda
guy.
like a
And there's
bad-
almost like a hint of
Yeah,
another
yeah.
loop below it too, huh?
Yeah, like kind of like out of the focal point or whatever.
Right.
I took the little number things off of the side, but this is like 3-ish centimeters. So this is what a small bowel looks like, and I don't remember what this one was. And you're right. There's definitely over here like maybe a little hint of another piece of bowel, but I remember with this one, like this was the only loop I could find, and this was like a residency clip. So I don't know, like maybe this one was that one you were talking about, where it's like a closed loop obstruction, and only like one loop is messed up.
Yeah. Yeah.
At least early on.
Yeah, you got to
Here's
worry about
another
those.
image right here. This one's a little more, I think, obvious.
Right. That's like your classic
Yeah, it's
small bowel
super
obstruction,
dilated.
ultrasound. Like you got the back and forth peristalsis, you got multiple dilated loops. It's just filling up the entire screen. Like that's clear.
Yeah, gross. Super gross. What about this guy right here?
I see more free fluid there too, about around the bowel. Looks
Yeah.
dilated. Yeah, looks gnarly.
Yeah. Yeah, and it's important to note that like sometimes you'll see poop on the inside and sometimes you won't see as much poop. I wonder if what's happening is like down here, like the second loop, that one has more actual stool, and then the part above is more kind of like inflammatory, like fluid exudate getting into the bowel there, and that's why it's so like hypoechoic.
It's hard.
Or it might be like a loop of the bowel that's like further down, and whatever that was in there has been absorbed.
Yeah, I mean-
but you don't always see poop.
Right, but it could just be like delay in transit too. Like you could have, Mountain Dew at the top and Big Mac at the bottom. It just hasn't really mixed yet,
I thought about that. Yeah, the Mountain Dew and
Although Mountain Dew would probably be
some
more
of it.
carbonated, so you'd see more bubbles. But
That's right. Now you see this little triangular thing right here? What
No.
is that? What even is that? Bowel. What is that?
The little triangular thing. What are you talking about?
Yeah. So I don't know why I like my mouse. Oh, there it is, right here.
Oh yeah, that looks like free fluid.
It's like a little. Yeah, it's a little triangle of free fluid. Do you know what this is called?
Triangle free fluid sign.
That is probably better than what it's named. It's called a Tanga sign.
Oh, Jesus.
And when I was in residency, like it probably took me a full week of like trying to figure out who named this and why it was. I finally was able to locate a textbook, which is where all the studies like referred to this sign. And in the textbook, it states that it's called the Tanga sign due to the swimsuit bottoms that females and I guess males can wear, the Tanga swimsuit. And so that's where that little triangle thing comes from. So it's not anything fancy. It's not like named after a famous researcher, which is what I thought it was.
I didn't even
Literally it's just
know
like type
a
of
male
underwear.
bikini was called a tanga.
Yeah, that's right. Small bowel obstruction has never been sexy.
So, how did you know that, Jacob? Did you already know that, or did you have to look up tanga?
No, I told you. Like I had to look it up. Like
No.
I found all the
I know you
studies
had to
that
look
talked
up the
about it.
but did you have to look up what an actual tanga is, or did you already own and know what a tanga was? I'm trying to get at, do you wear a
So
bikini?
I'm not going to comment on like what I do outside of the podcast, but I will tell you that if you Google Tanga, the first thing that pops up is like a woman in like a bikini bathing suit. So you can try that out if you want.
Are you actively wearing a tanga right now?
I mean, I'm not going to stand up, so you'll never know. I may be.
All right.
I don't know.
Fair enough. Now I'm gonna remember
lastly-
that. Like that's unfortunate that I'm gonna remember that now.
Yeah. You're welcome. So lastly, I want to talk about the difference between a small bowel obstruction and a large bowel obstruction on ultrasound. The big thing for me is basically size. Look at how massive this is right here compared to like the small bowel over here.
Oh, so
this
that's
is a
large.
large bowel
That's
obstruction up here.
that's
This
not
is-
liver up there. I thought that was just a big old. Oh wow, man,
Yeah.
that's impressive.
No, this was a colon cancer actually, like a distal colon cancer that was causing a large bowel obstruction, and the small bowel obstruction is below it. So this one's like both. Like the small bowel obstruction is due to the large bowel obstruction.
Man, that's gnarly. So, Jake, we haven't talked a lot about like how you actually perform the scan. I mean, we said like you put the probe on the belly, but
Right.
I mean, how do you go about learning this? Do you have to? I mean, it's not like we have like simulation models or anything where we can like train this sort of stuff. I just feel like we need to talk a little bit more about how you actually do the exam and how you get better at it.
Sure. No, that makes sense. Like basically practical applications, like how well can we apply, this information and use it clinically? So that's a great question, and there's been two studies that have looked at that. The one on the left here, it had a 6-hour training program and enrolled 4 EM residents, and they enrolled 174 patients. So it's kind of like a lot of patients here. And then the study on the right, it's even a little bit crazier because what they did was they only did a 10-minute training module and then had them do 5 exams and then enrolled 76 patients. So this is 10 minutes here on the right side of the screen. It's kind of crazy. And look at these sensitivities and specificities. Like,
That's
what do you think?
impressive.
So 6
Those
hours
are-
of training,
those are big
10 minutes
numbers.
of training. I know they're nearly 1. I mean, these are like phenomenal.
Just think about how
numbers.
pissed off those people in the first study are that they wasted 5 hours and 50 minutes. You
I
could
know,
have
I've
gotten
been mad.
so much done.
Yeah. I know you could have gone mountain biking. You could have fixed things in the house. You could have mowed the lawn.
You could have done a
You know,
lot.
there's a-
I wonder if you
Yeah.
could you teach somebody this in 5 minutes?
I don't know. Maybe
if
that's
there's-
the next study.
If there's no improvement between 6 hours and 10 minutes, then how about 5 minutes? What about 2 minutes? What if you just don't teach
Yeah.
people? Just give them an ultrasound machine and see what happens.
So go look. Just tell me what you find.
I mean, honestly, small bowel obstruct, like the images look so easy that it almost looks like you could do that, right?
Yeah. No, it's one of those things that once you see it on ultrasound, you wonder why you haven't been doing it already.
Right.
Because it actually, like, it's probably, I think lung sliding is probably the easiest ultrasound examination to do, and I think that small bowel obstruction is the second easiest as far as
I agree
actually
with that.
getting
You know what?
images.
I will say though that like the older I get, I think the more I realize that just because you can make the diagnosis doesn't mean that you know how to treat the patient. Because
Yeah, that's
you
true.
know what I mean? I mean, like
Yeah,
it makes
yeah, you're
it's
right.
easy for us to say like, small bowel obstruction, call surgery. But it's kind of hard for the surgeons to say like, well, yeah, there's a small bowel obstruction, but are we going to operate on it or are we going to sit on it? And
Yeah.
and I'm not sure ultrasound's that good at giving you that answer, right? I mean, I guess clinically you can make that determination, but I don't know. Have you come across anything, Jacob, where they like really talk about like operative intervention for these small bowel obstructions with ultrasound?
I feel like you have seen these slides before. So it was like a perfect segue to this point right here, which is the limitations of it. Yeah, we can diagnose it, but what do you do with that data? And that really just depends on the patient. And to answer your question, no, there's no data that looks at what the outcomes are when you find this on ultrasound, which I think is what you were asking.
Right.
It's very difficult to find the transition point, if at all. A couple of times, just anecdotally in my own practice, I will find a bunch of loops of bowel, in the right upper quadrant, like looks classic small bowel obstruction. And if I look on the left, I can't really see anything. So when I see like small bowel obstruction is mostly in one area of the abdomen, I assume that there is a definitive like mechanical obstruction that might be able to be surgerized. But in those cases, we usually have to end up getting the CT scan anyways, typically.
Right.
Right. And that's actually okay because you have a patient. I mean, abdominal pain is an extremely common complaint that we see in the emergency department, right? I mean, we see it all the time, and this helps speed disposition, which is a good patient-centered outcome because the more time that you delay treatment for small bowel obstruction, the worse they do as far as morbidity and mortality. And there is definitely research behind that.
Right.
Yeah.
What do you
So-
think about the use of ultrasound as a rule out for small bowel obstruction? Like, so I see how you probably end up getting the CT a lot of the time in patients who do have a small bowel obstruction on ultrasound. So
Yeah.
maybe ultrasound might get you quicker to the CT. It might, maybe be helpful in people who've had lots of small bowel obstructions that get watched a lot. But what about like rule out? Are you comfortable, like, somebody comes in, they've got some diffuse abdominal pain, maybe they're a little distended, your pretest for small bowel obstruction is fairly low, put the probe on the belly and you don't see dilated loops. Are you done?
Yeah, so that's actually like a great question. And to answer that as quickly as I can, the answer is yes, as far as small bowel obstruction. So it's if you have a low pretest probability. I feel comfortable with my ultrasound due to, data in PubMed, like in the literature. There's data that you're good. But
due to, data.
due to facts and science, I think you'll
based on facts and, the scientific theory, I think that, yeah, I'm good.
Right. But I mean, if I had somebody that I had a super high suspicion of a bowel obstruction, like, they've had like 20 abdominal surgeries, they've had 25 small bowel obstructions, and they have pain and they're like, this is my small bowel obstruction, and I don't see dilated loops of bowel, I probably am going to get further imaging. And that's important with all ultrasound examinations in general. I mean, I kind of harp on this a lot, but the ultrasound is not the only thing to do as a physician. It's a tool to help you out. And there's times when the ultrasound doesn't match up with everything else. And you have to kind of decide with your brain what to do with the ultrasound data point if it doesn't match up with everything else that you're looking at in front of you. And oftentimes that doesn't happen. Like if they don't match up, I get the CT scan, and that's actually perfectly fine. I'm okay with that.
Yeah, I think we're personally really bad, especially on this podcast, at just talking about how awesome ultrasound is, and not putting enough time or taking enough time to talk about how you have to use your brain a little bit when you're taking care of these patients, and think about your pretest probability, and think about the likelihood ratio, the sensitivity or specificity of your ultrasound, and how that applies to your pretest probability, and whether you can really rule something in or out based on what you're seeing in front of you. Yeah, but hopefully we're getting a little bit better at that over the years. As we get smarter and better at using ultrasound, we can talk about that a little more, I guess. Cool.
Yeah. And then another like small limitation. Well, I mean, it's not small, but another limitation is discomfort. I mean, patients have belly pain usually when they're coming in with this, and you're kind of pushing on their belly. So I make it a habit of giving these guys, if I suspect that they have an actual abdominal pathology, I'll give them some pain control usually before I ultrasound. Just because I've had belly. I remember when I had my appendicitis. When I was in med school, I didn't really have that much pain medicine because I don't know, I just didn't. And then you had the med student that was on surgery come and push on your belly, and that hurt. And then you had the resident push on your belly, and that hurt. And then you have the fellow come and push, and then you have the attending come and push, and all that hurts. So just remember that these are patients that have pain. Give them some pain medicine.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.